Allowing the mental health standards for patient safety areas covered, Wieczorem odpowiadamy za to na Okay, thank you. Maybe it will not take an hour. I will try to do that in 45 minutes. But at first, I had some question during the break to know what kind of hospital I'm managing. It's in the past, it was a really big psychiatric hospital with an asylum mission. At that time, it's a really big hospital. We had 5,200 patients interned in that hospital. Without not very much chances to go out. And it was a city, a kind of city with any kind of services. We are not in the center of Quebec city, but part of the metro agglomeration. So what happened in the 1960s, there was a movement to bring patients out of the psychiatric hospital, and then funds from government were invested in the primary care level to receive those patients, and that means that now it only stayed 100 of those people in the hospital. They get older, they have complex psychiatric disorder, and there's no matter to try to have a citizen project for them in the community. And as they are getting old, it will decrease years after year, because we do not more admit patients in psychiatric long-term care in our province. So that means the services are well organized in the primary care level, not as well as we want, but it's the orientation. So it left me around 250 beds for acute care in psychiatric disorders, and that means in that a part of a kind of rehabilitation, because some of our patients, like yours, do not recover in 1 month, 2 months, or 3 months. It happened with depression, but with schizophrenia sometimes it can need 2 years to try to equilibrate someone treatment or some behavioral. So we have the name institute because in our province, academic hospital usually have many specialties. When we only have one specialty, we become an academic institute. So we also have the Institute of Cardiology. That means they perform the tertiary cardiology, surgery, graft, and all of that. So this is that kind of institute. So our hospital is a kind of one specialty academic hospital. And maybe I told you before, or I'll let you know. So you mean that shift from a kind of asylum to now a hospital performing at specialized level with big teaching expectations, and we had a quite big research center also on brain disorders and neurosciences related research. So it's that shift, that accreditation help us a lot to mobilize people and trying to review the way they were working and all of that. So for me, it was a big tool. Okay, is that more clear for you? Yes? Okay. But like in the first part, we will not only address specifically psychiatric standards, because those are linked with others, and that's what we will see. The quality framework utilized by accreditation touch, it's like having a graph with 3 axes and not 2. You have safety, you have quality, and you have all the providers or the resources you have to give care. That means human resources, that means physical environment. You have all of that, it's all linked. But if we look at that in another way, so we have a population focus. If you are in long-term care, psychiatric long-term care, your catching area is quite well defined, and you don't have to work to see if you answer quite well to the needs of the population you are deserving. But if you are in acute care hospital, you have to look at the fertility ratio. So will your obstetric will go up in the next 10 years, or fertility ratio in the population around is decreasing, and you will see your obstetric services decrease. It's the way we make the link with population need. It's the same if you are in a forest area, so you will have a kind of trauma that you will usually not see if you are in a hospital in the center of a big city. So it's the way the planification of a hospital have to take care of the kind of population is deserving. Many years ago, for us, we only looked at the people who came in the hospital. We thought that the person we have to serve were only those ones who came in the hospital. But with the years, we integrated data, statistics, census, to just look what kind of health problem were emerging in the population, and telling us we have to take care of those needs in the next months or years, and it will help us to adapt our services. So it's a first way to look at it. The second one is accessibility. I think you'll understand very well what it means. Safety is the same for also you can for security. The work life, so the workplace, the work life, those are important dimensions. For sure, that one is not at the first place, but it's the more important. Continuity of services inside your hospital, but with partners also in the whole pathway, and it's especially true in mental health, effectiveness, and efficiency. You see in the standards of Accreditation Canada, you have all across the hospital, and we saw that before, you have standards for leadership, the way you're planning, the way you're making place for improving quality and safety delivery of care, governance, and in international standards or Accreditation Canada International, they put upside infection prevention and control and medication management, having a look on them all over the hospital. So you cannot be accredited if you're good in medical management in 1 or 2 units. You have to reach it in the whole hospital. Same for infection prevention and control. You will not be accredited if you're good in one part of the hospital and not good on the other part. It's all over the hospital. And then you have population health. Those do not apply to your hospital. Public health, animal health and food safety, population with chronic condition, maybe depending on the services. But in acute care, you should see psychiatry also, mental health, because in Quebec province, psychiatry is included in mental health. So I'm a mental health institute, but namely psychiatric hospital. But we use mental health for mental disease. Psychiatry is a part, and there's some others. So we should see here, it's not there, but we should see psychiatry. You have ambulatory care, we should see psychiatry also, because in my hospital, the death decrease, but the outpatient number, it was zero 50 years ago. Now we follow around 8,000 people in the community. We have a lot in the hospital, but we have also 3 places in the town where psychiatrists, psychologists, therapists, social workers are working with people followed on an external basis by a specialized team. So that means 8,000 people followed by our ambulatory care. Laboratory, depending if you have it. Primary care, I think this is not relevant for your organization. And community care, you have home care. You can have also services, mental health services. It's depending the way your health system is organized. And then, I think this mention is the most important, is that mental health has standard for acute care, ambulatory care, and other related topics. You will see that in a few minutes. I will not go very deeply with that, but it's the way you have standards and you have criteria and the way it can be addressed. So you have subsection heading, so building a high-performance team. The standard is, this one is the operating room. The operating room team uses a multidisciplinary approach to deliver services. This is the standard. Just put mental health, and the answer will not be the same, but the question will be the same. And then you have the 2 criteria applying to that, and each criteria, this one refers, you remember, right? You had the one, this one refers to efficiency, and then it's associated with a level of accreditation. So you have gold for the first, platinum, and diamond. In that example, it was diamond here, it was gold there, and it was platinum here. And you have, under each standard, some guidelines to interpret. I talked before, and Sébastien a little bit also, that there are some practices who are required as a foundation to reach the accreditation. And you have those ones here. We call them required organizational practices, ROP. One is client verification, double identification. Another one is transfer of client with information at transition points. It applies to every specialty, but it takes a special color in mental health or psychiatric hospital. Medication reconciliation, our first technology. Safe surgical practices, unless you have, how can I say, I don't know how you call that, if someone needs to have some sutures or something like that, you have to take care of that material, but it's very, very small. Dangerous abbreviations, you can have that in mental health also. Control of concentrated electrolytes, maybe it doesn't apply, but it's applied in my hospital because I missed to tell you that I had 10 beds operated by a family physician who take care of physical conditions for the patients who are hospitalized in my hospital. So if one starts pneumonia, he will be admitted in these 10 beds, treated there by the psychiatrist and the family doctor, and then return to his unit when the pneumonia will be treated. Maybe if it's a myocardial infarction, then you will be transferred to the cardiac cardiology hospital. But for many, many physical conditions, the patient stay in the hospital, and it's better for him than going in a general hospital and being, disturbing or all mixed up. Higher medication is applied. Infusion pump training, I think not. Training on patient safety, yes. Preventive maintenance program. Even in psychiatric hospital, we have those glycometer, to measure glycemia for the diabetic patients, and maybe some other equipment. All small they are, we need to have care. I don't know if it apply to you. Falls prevention, venous thromboembolies for orthopedic surgery, so you will not have that. And hygiene. I don't know how it works here, but it became a religion in Canada. Because we have a lot of problems with infection. We have that Clostridium difficile who made too much number of deaths. And then our government and our Ministry of Health in all provinces started to have expert committees in each province, and then having guidelines on universal precaution in infectious disease control and washing. So we will find sign on the wall. Even in psychiatric hospital, we have distributor of product to wash hands. We made studies and we didn't put liquid. We put a foam just to avoid that patient will drink a lot. And many employees in the hospital were very aware when we started that patient will become intoxicated. We cannot do that in psychiatric hospital. And we found that sometimes in those approaches that we still have in mind the way we treated patient before, and we have in mind quite the same condition as our patient themselves. We think it's always different, we're not like others, we will not recover of that. Sometimes our employees are thinking like that also. So we put that in place and we have no problem at all. But patients are washing their hands, personnel also, and we had in Canada a standard that we have to audit, evaluate the percentage of compliance to a good hand washing. And our infectious disease nurse have a special product, people put on their hand and they wash, and then under a special light we can see if they wash the whole hand or only a part. So it's the way audits are done, but those are very important standards for us. I don't remember, Sébastien, is there Sébastien? T'es là. Est-ce que hand washing, this is in international standards also, right? Those 2 pages recall the practice you have to encounter if you want to have the first level of accreditation. Those are very critical.
The Wi-Fi enabled.
It's quite the same as before, but that one maybe was, yes. Okay. I told you in the first part that annually, Education Canada has an annual report. I show you something, but they also highlight what were the best trends all over the 368, if I remember well, the hospital who were visited, hospital or health services organization. And always when we do a survey, as a surveyor, in each category of standard with whom we meet, we always report with comments what are the big trends or successes and what are the area for improvement. And we try to balance. We usually put 2, 3 to 4 what are good practices in place and what are the 2 or 3 that should be improved. And you can think that it will start the beginning of the plan for improvement. So all over the Canada, the big strength that there was, the higher was infection prevention and control. But as I told you, with the problem we have with some bacteria, the level of consciousness was becoming higher and higher and higher. But it is reflected in that, when we look at that. Annual training on safe care delivery. I can say that 10 years ago, it was almost not in place. But with the standard which saw, every hospital or organization put in place training, because we all have some training program in the hospital all year long. I should think it's the same for you. Maybe depending on your budget, you have a little bit or you have more. But when you're in the accreditation process and you see priority like that, you just reorient your training program in safety care delivery. And also, and it wasn't like that before, incident and accident is going up. As I told you, we have from our government and ministerial health a new standard for the whole province, and then new tools, computerized tool to have all of that report. And with that, we have to report. Inside the hospital, we have to analyze, and we have a policy in the hospital to divulgate to the patient if something happened that can be harmful to him. So if he receives the medication of other patients and that medication can be harmful for him, we declare it to him and he knows the patient that we are following him for maybe 24 hours with some tests just to make sure nothing wrong will happen to him. We have in our standards in Canada a standard for that. But I don't know internationally. I don't know internationally speaking if there is a standard to divulgate when an incident or accident also. Okay, because I'm not so sure the reason why I take care. For opportunities for improvement, we saw all over the Canada that preventive program for equipment and medical device wasn't strong enough. That means that in a big academic hospital, you can see the kind of machine, equipment, and any kind of thing. But good standard means that you should have a list of your equipment. You should have the maintenance program for each equipment, facing when it should be replaced, and having also a list or a register of any incident or accident will happen with that kind of equipment. And then you manage in a more efficient way all your equipment. Avoiding abbreviation and dosage involved for medication. You know, doctors especially, but some other professionals also, that doctors prescribe. You know, we all learn with abbreviation, and sometimes some were at one university and teaching hospital, someone somewhere else, and the abbreviations are not always the same internationally speaking. So it's the reason why in the standard we have to list all the abbreviation and say we will no more respect those abbreviations on the pharmacy work. If because too much accident, happen with that. And it's the same for medication reconciliation. When it came in the standard, I think it was 3 to 4 years ago, the standard said you should have it all over the hospital. So the first year, there was maybe over my 10 hospitals who were able to attain that. So Accreditation Canada said you have 3 years to implement this. The only thing we ask for the first year is that you have 1 unit who implement the whole process and just fix your plan over 3 years to have all your units being able to have reconciliation of medication in their unit. So that's what happened. But we were in, it's between 2009 and 2012. I'm sure it's better now, but in that period, it was really like that. But when you have a survey, on-site survey, and the surveyor will pass through all the standards, when they have a set of standards, they will put comments. We saw that something is starting, they are working on something who will become in a few months, and then surveyor put strengths and they put opportunities for improvement. And usually, opportunity for improvement related to standards who are not attained. And you will see that the report and the plan for action will be a copy of that. Priority process in the accreditation. I told you, you have 3 axles. We saw one with population, all of that. We have quality, we have safety of care. But going in a hospital, standards touch, even in mental health and psychiatry, you have something in all those places who can relate to mental health or psychiatry. If we take governance, I told you before in the first part, what we are looking for, does the mission integrating quality and risk management in the mission statement? Would you be general hospital or psychiatric hospital? And there are standards to analyze quarterly report on quality and safety. You will see that leadership or direction should have those reports to the governance. Leadership, human resources, safety training, patient information, patient protection during construction or some work in the work. And for construction, you know that legionellos, amiante, qu'est-ce que c'est amiante? You know that kind of fiber, sometimes asbestos, yeah. So we have taken all of that. Water supply, preventive equipment maintenance, integrated risk management approach, and quarterly report to government. Would you be in psychiatric hospital? Those standards apply. Ambulatory care. So we find in ambulatory care, when you have a hospital with ambulatory care, psychiatric hospital have adapted elements from episode of care, ambulatory care for general hospital. Medication management, double identification, drug events reporting, medication reconciliation, admission and point of transit or transfer, emergency and disaster plan. That plan should address the continuity of care. If you have a fire and have closed some units, how will you recycle patients? What kind of approach will you have for your personnel, for your patients? And we have standards for training, on fire or other disaster, bomb alert, I don't know what, and simulation. And simulation is a quite hard thing. People say we cannot do that with patients with psychiatric many. But what hospitals do, they make simulation and not real evacuation. And sometimes one part of the personnel know that there will be another, and the other part doesn't know. And people do what they have to do during the simulation, and then the analysis is very, very helpful, because then people can identify what doesn't work, and there's always something that doesn't work. So if it will become for true, people will be more prepared. Emergency department, we have special standards there, but it's adapted also from medicine. Infection prevention, safe injection protocol, vaccination. I don't know if your psychiatric hospital, but in mine, we should have vaccine for influenza, pneumonia vaccine for people older than 60 or 65. We have just that Vaxxed soda for influenza there. I think